Now it's recording. Welcome to our podcast, everyone, about patient-centered communication. I'm Chris Haymaker, and I'm here with Kari Beth Watts. Kari Beth, could you say a little bit about yourself for our avid listeners?
Yes. Thank you for having me. I am Dr. Kari Beth Watts. I am a board certified family physician, also board certified in addiction medicine. And my entire career has really been in the medical education space, working as full-time core faculty for family medicine residencies, as well as spending some time in the undergraduate medical education space with clerkship activities. So yeah, that's really been my professional home and my clinical practice for the last 7 years or so.
Well, I'm so pleased that you've been able to join us this morning. Folks might know that I'm a clinical psychologist who is trained as a pediatric psychologist, and I've been interested in communicating effectively with patients for such a long time. And really, more broadly, interested in communicating effectively. And so I guess I'm wondering, is it okay if I call you Cara Beth?
Of course.
Lovely. I guess I wonder, as you're thinking about communicating with patients in maybe an outpatient clinic, what are some of the core skills that you think of as you're navigating those encounters?
I think the first one that comes to mind is, and I think of this too, I can't help but think of it not just as in my lens as a physician, but as an educator as well, who's doing a lot of walking alongside medical learners, particularly residents. Um, you know, interacting with patients and conducting interviews and providing education. And I think that one of the core principles to me is um, getting permission from the patient to engage in whatever topic is on our agenda. We come with this physician kind of centered agenda. When we talk about patient-centered communication, of course, there's that piece of eliciting what is most important to the patient. But the pitfall that I encounter most often, or that's probably the most important to me, is really when we're providing education or counseling, making sure that we have permission from the patient and engagement from the patient to explore whatever topic that is.
Right.
Um, I think a lot about, activity, physical activity, movement, and diet or nutrition. Those are spaces where physicians just love to give advice. And I think
Mhm.
when we talk about patient-centered communication, I want to move away from the giving advice space
Yeah.
to providing education that's tailored to what the patient needs from us that day or
Yeah.
in that season.
Yeah, it seems to me that there's a lot to navigate before you land in that space where you're talking about what a patient can or should do.
Yeah,
And permission is really one element, I think, of explicitly communicating about what's happening between the patient and the clinician, the resident, the
yeah,
physician, right? And before you get to that point where the clinician like has those ideas, I'm going to give you my best physician advice.
mm-hmm.
What do you think of as the most relevant things so that you can get there and be in a position to ask permission?
Yeah. I mean, and I think that starts at the beginning of the visit with eliciting their objectives for that day, or and not just to talk about that day, but then like their objectives for their health, like they're coming with a specific need or concern. And so um how do we explore what their goals are? Because I think to get to a place where you're giving advice, you want to have as much context as possible. And that really is something we need to elicit from the patient specific to what their goals are. So I think about an example that just happened in clinic yesterday where a new learner, right, is in clinic, a new resident, and a patient wants to lose weight. Such a classic example. And the physician very earnestly gives a really realistic stepwise plan for movement. But what had happened in the half hour leading up to that advice giving was the patient also describing chronic pain, right? Limitations with activity, limitations with access to spaces to move or exercise, concerns about what that would do to their body or their chronic pain. And then, kind of in a silo separate from that, was this physician directed response. And so, I think really being able to kind of mine and leverage and explore or be curious about the context that the patient's bringing with them is huge. And that's hard to do in a focused way, which is why we have folks like you that help us build skills around that.
Well, it's a really, I think, complicated task. There's a lot going on in that patient encounter. And if we can just set the like electronic health record aside for a
Yeah.
moment, which creates its own separate cognitive load, at the very least, physicians are building a relationship and also navigating clinical decision making
Right.
and trying to marry those two things up. So you have to connect with this patient really skillfully.
Mm-hmm.
And then as you're having the conversation, elicit enough information about context so that you can individualize what you
Mm-hmm.
need to say from an advice giving perspective or from a medical perspective, right? And
Yeah.
that's tricky to do when you're a new learner, or when some of those skills might be a little more uncertain.
Mm-hmm. Absolutely. And it is such an understandable, again, it's kind of a non-judgmental space for that learner to recognize or look back on, oh, you're right. I really launched right in um, to my spiel and wasn't thinking in that moment at all about about all the things we had talked about in this other kind of bucket earlier in the visit. And we all do that. And so I think that, being able to kind of mine that visit, and as that we're going and we're doing some of that clinical thought process, kind of using those skills to kind of build our list or our menu of what are some interventions that we are starting to wonder about that might be helpful, and then kind of finding thoughtful ways to offer that, kind of menu of interventions or whatever the problem might be, next steps, we'll say, thoughtfully offer some of that menu back to the patient and really engage or elicit, like, what of this feels good to you, or what of this feels realistic to you, or which one or two would you pick if you could focus on just one or two things, or take one or two steps toward whatever we're managing. And I think that's the approach to try to lean into over, like, here's my plan for you. That here's my prescription.
Yeah.
Um,
I mean, I think one of the other skills, in addition to asking permission and maybe eliciting some of that agenda up front, one of the things that I'm often encouraging people to do when they're getting to a point where they might have an idea about their plan would be to wonder, you use that word wonder,
mhm.
about what patients know or have tried to
Yeah.
address the problem first.
Yes.
And one of the things that I often say when I recommend that, is this is a strategy that is going to make you look so much smarter because then you aren't going to give advice that the patient already knows about or
Yes.
has been really invalidating. There are all kinds of reasons why physician advice fails. One of them is that it doesn't really connect up with the patient's individual history. And it's just so easy to ask the question, what have you tried? And
Yes.
then to connect up like you said, one or two next steps as
Yes.
opposed to all 16.
Yes. And I love that point and appreciate you bringing it up because I think you and I have both seen, and in our particular workplace, we have the benefit of being able to do some video precepting and watch some encounters, and also being in the room with learners or ourselves, lived experience for sure of being in front of a patient and just watching their eyes kind of glaze over or watching their face kind of fall as we enter into this spiel that they are really hearing as, and understandably so, you know, sleep more, move more, eat better, or whatever the version is, be healthier, cut back on salt. And they know it.
Yeah.
And so you're so right that sometimes the things that we are more afraid to do, sometimes we're afraid to communicate about side effects. Sometimes we're afraid of asking those open-ended questions because it's so much easier to just tell them what we know, right? That's simple. And um, and not a heavy lift. And in the end, tailoring that education, being able to kind of help shape or anticipate the future for patients not only serves them better, but it makes you as a physician so much more trustworthy, even when you're talking about tricky things.
It's also,
So
I would point out, much easier, really, right? I think that
yes.
we all fall into this trap of, if I can coin a term, clinician splaining, or right? So that like
Yes.
there are 13 things that I could name about how to move more or eat
Yep.
healthier or whatever it is, easy enough to drop into that. And if I do, um, then I'm going to
You're gonna
run
lose them.
behind because I have to
Mm-hmm.
say all of that. I'm not going to hear key pieces of information from my patient because I
Mm-hmm.
was talking through all of those things. And my patient is going to either shut down, zone out, roll their
Mm-hmm.
eyes, not come back, all of
Yeah.
those things that
Yeah.
in the long run are really creating more barriers
Right.
to patient-centered care.
And don't you think, not only do we not look smarter, but we kind of inadvertently a lot of the time or unintentionally, when we do that, we are making the patient not feel very empowered or smart because we are, by virtue of just clinician splaining, really saying to the patient, I assume you don't know any of this either. And it's
Yeah,
pretty basic stuff. And if folks have been alive in the world for very long at all,
yeah.
they've heard about it, portion size, or they've heard about, you know, salt or exercise or blood pressure. And so really being able to ask what they know in order to give them credit for the lived experience of having that chronic condition and having managed it for however long, diabetes, or living in a larger body and having navigated that from a health standpoint. All of that is really, but it's a bi-directional trust building, right? We are
Yeah.
demonstrating thoughtfulness and intentionality and tailoring things to that person. And we are also giving them space to show us what they know about themselves, who they are experts on, and building trust that way because we're investing in it. And ultimately, whatever you solve or don't solve that day, you want to leave the encounter with a feeling of welcome and invitation to continue to walk this, road together. You want them to continue to feel invited into your office. You want them to continue to feel invited into this partnership of building health, and that can be achieved a lot of ways. We don't have to dump everything we know in every visit, and shouldn't, for all the
No,
reasons we just talked about.
no, definitely shouldn't. I mean, from a behavior change perspective, the more things you try to change at once, the fewer things you are going to change
Yeah.
ultimately, right? And from a medical management perspective, right, clinical decision making it's useful to set priorities and effectively address either the high priorities from the patient's perspective or medically the most
Mm-hmm.
urgent problems. And without setting some of those priorities, it just really becomes a jumbled mess.
Mm-hmm.
I wanted to sort of return to that idea because of of uh, of an invitation, and
Mm-hmm.
we talk from time to time about
Yeah.
reinforcing one another's agency, right? Our
Yeah.
ability to be in the world and change things. And then I also think that there's an invitation there to navigate uncertainty with
Yeah.
patients in a really healthy way, right? Let's try a couple things and see if these can work for you.
Yeah.
And it's possible that they won't. I have
Yeah.
lots of other ideas about how we
Yes.
can make them work better or modify them or substitute other strategies. There's a lot out there and we'll
Yeah.
find something. And so, even by communicating that uncertainty, you can wind up in a situation where you're also communicating some level of optimism in a lot of
Mm-hmm.
situations that something will come up that's going to be
Yeah.
effective rather than this is the same old cookbook and the
Mm-hmm.
same old recipes,
Yeah.
and I do not care about your feedback.
Yeah. This is what I know works.
Yeah.
I appreciate that so much, and it addresses another point I want to make about that invitation to continue the relationship, the invitation to come back as you are. And I will talk to learners about this and to patients to go when I'm trying to coach someone up on having some sort of behavior change conversation, right, with a patient about smoking or that idea of ending it with, you're going to set with the patient a couple discrete, goals, or you're going to agree on a couple next steps, like you just said. And I love the scripting you use. What I always add is that you are I in a month or whatever time frame we decide that you're going to come back and we're going to check in on this. This is not a check-in where this is a non-judgmental space. You're going to come back as you are. And you're going to know that me as your physician, I'm going to accept that if you come back in a month and you have gone down by 0 cigarettes per day or 2 cigarettes per day, whatever, that is fine. That
That's
is a
information.
conversation.
Yeah.
Yeah. And so that piece of going, yeah, there's a couple elements of that. One, just really anticipating with them, okay, it sounds like we've all agreed to start here with 1 cigarette, or we've agreed to start going down to 1 Dr. Pepper a day, or whatever, that feels right to you and good to you. And also, it might not work out. And so let's come back and just talk about that if that's the case. Well, then we'll have a conversation about why that is and what else we could try. I love you saying, I've got lots of other ideas. I think it is in that same vein of talking about like teaching residents and stuff, learning to talk about adverse effects of medication or side effects of going, we're afraid to talk about maybe this will work, maybe it won't, maybe this amount of insulin will work, maybe it won't. We're sometimes so convinced we need to be sure. But a physician once told me that when you can predict the future for a patient or a parent, again, it's that trust building to go, oh, this my physician told me that this might be really hard, or my physician told me this, I might feel this way on this med, or my physician anticipated with me that this might be a hard behavior to be consistent about, and this isn't working as well for my schedule as I thought, and I want to try something else. And just that permission for it not to work. It's like you're giving the patient permission to to be imperfect as well, which is really important because you and I both know they come back and they feel like they need to give us a great report card. And I'm always really uncomfortable with that dynamic because I just don't want them to feel like they owe me a particular way of being. So yeah,
Yeah, I mean,
I
I think that there are lots of things along the way that we can do to send the message that
mhm,
we want patients to be their authentic selves.
Mm-hmm.
I think some of that is maybe asking permission, and some of that is those curious, pertinent questions about
Mm-hmm.
the health or illness narrative that are going to deliver the context. And part of it is maybe, querying with curiosity what people have tried, and then a healthy dose of sort of both confidence in the
Yeah,
evidence that we
correct.
have and humility
Mm-hmm.
that we don't always know all of the things
Yes.
that can then really invite people, I think, to be more authentic, more frank, about what's going well, what's not going
Mm-hmm.
well, what they want help with, because I think that's another thing that we haven't spoken very much about that is often a frustration with our learners is when, maybe after a few repeated appointments related to smoking,
Mm-hmm.
uh, someone will note, I'm really frustrated that this person is non-compliant with
Yes.
their smoking cessation, and they keep talking about how terrible their COPD is. I just don't
Mm-hmm.
understand why they don't quit. That would be the best thing for them.
Mm-hmm.
And and then the maybe the conversation there about how to frame that in a more patient-centered way so that frustration doesn't wind up contaminating the encounter with
Yes.
judgment and failure and uh,
And that's us really centering ourselves, right? And while um and there's some, yeah, degree of kind of, well, there's a lot of factors that lead into that. But when I have those moments, which are human, right? Um, I think of something you have said before in teaching our learners, which is that folks are, um, they if something else is falling through, right? If they're not quitting their smoking or they're showing up late to appointments, they're usually solving a different problem, right? And so having some curiosity about what that is to kind of pivot back into that patient-centered space, and also ask ourselves if we can be more flexible with our goals for the patient, right? That again, the effort is really a mutual agreement on a path forward, and not necessarily needing to be married to a specific timeline or outcome in every case, and then all of the judgment and feelings that come with not leading up to that. Because what the patient's left with, if we present them with really, we can present good clinical evidence and a great evidence-based plan, and like you said, can and should do so with some confidence or make recommendations that guide next steps. But also, if we lean too far into the physician directed prescriptive type of communication, when it doesn't work out for whatever reason, that is a social determinant of health or something that's personal to the patient, what they're left with is oh, well, I am the problem. you know
yeah.
my physician has presented this perfect, plan of solid medical knowledge, and so trying to make room for the fact that there are ways that things can not work out, that aren't things the patient needs to internalize as fatal flaws in themselves. Like,
Yeah.
part of that patient centeredness, I think, is still trying to um, nurture their interest in improving their health, or just still nurturing whatever that kernel is, and going, okay, there's a lot of ways this can manifest, and maybe quitting smoking just isn't the thing that's going to happen right now. And we have to learn how to let that go too, and go,
Yeah.
it's going to look like something else right now. And that's okay, because it's this person's life.
Yeah, and I think one thing, one really quick communication technique to reinforce some of that agency and to um and create that separation between the human and
Mm-hmm.
the maybe behavior change goal or the the illness or whatever it is that the
Yeah.
physician might be thinking is not working, is to ask just what's getting in the way.
Yeah. I love that. What's getting in the
And
way?
and that exploration of barriers might lead to a real shift potentially in treatment goals. It might lead to
Mm-hmm.
some really specific problem solving that could address that narrow behavioral goal.
Mm-hmm.
But in either case, it also becomes an opportunity to sort of normalize that human experience that the patient
Yeah.
has happening. And as you were talking about it, one of the things that I'm aware of is that there are a lot of times when I see learners, particularly junior learners, leaning into talking about the evidence.
Mm-hmm.
And I often am struck by how little that establishes credibility
Yeah.
with patients, because often what establishes credibility with patients is that you establish rapport, show an interest in the patient outside of their illness,
Mm-hmm.
and um, and that you listen.
Yeah. Yep. That is, yeah, that's exactly right. And to get back to the first point, what is getting in the way is such a great non-judgmental but curious question. And even that difference of what a big difference between what's getting in the way and going, why aren't you,
Sure.
which we might even not feel like we're saying judgmentally, but like, oh, well, or why can't you? And it might just even be some of those instinctive ways that we're trying to ask a curious question, but it automatically is kind of this blaming or this inadequacy, just
Yeah.
to kind of go, huh, yeah, what's going on with that? What's getting in the way? Is I think such a refreshing and helpful and again, really patient-centered but non-judgmental approach there to being curious. And then, yeah, I think that your latter point addresses, circles back to what we were talking about earlier, which is, and I think largely the theme of this conversation, which is just us as physicians or clinicians kind of gently confronting our own um, preferences, experiences, tendencies, impulses, I would say, in these encounters to um, share our knowledge, to build credibility by educating and citing sources and things. And really, really, the call from our patients is to simplify and to focus and to tailor. And I think that feels like not enough for us.
Yeah.
It
Yeah.
feels, but once I think you do it and get that reward enough times, it will be a self-fulfilling behavior change because the relationships are so much richer. And there's a parallel there in the addiction world with harm reduction, really, too, right? Of just going, um, it's extreme patient centeredness, right? It's going, let's get at the very core of what will keep you safe or what will keep you well, and really peel back all the extra layers of what would be perfect or ideal or what I would want for you if you were my loved one and I could pick. And there's a ton of parallel there that has taught me a lot, I guess, about applying those principles in a less radical way to just everyday encounters of going, oh, my biggest job here is just to care about this person and kind of get at what the next step is for them to, that they're bought into to improve their health or this condition or
Yeah.
um, so
Yeah, across a sort of a continuum, I think that listening and communicating that you understand with some empathy or compassion or validation is really critical to get to a point where you might just efficiently say, because you've developed a relationship with a patient, I recommend Tdap.
mm-hmm,
I'll have the MA set that up for you.
mm-hmm,
And then, of course, you have all the evidence in your brain
mm-hmm,
about why that recommendation is the best one for the patient. And if you have that relationship with a patient that you've established through patient-centered
Yes.
communication, then that just really efficient statement does a lot of work for you.
Yes.
And you don't have to deliver all of the evidence to every one of your patients, although there
Hmm.
will still be some folks who will ask the questions, well, I mean, what is that? And how is that helping me? And
Hmm.
there are various formulations, but you can just say without a lot of evidence, if you've validated and communicated your understanding, I
Hmm.
think I think these are the best two recommendations. What do you think?
Hmm.
And then get into a more depth conversation to the extent that your patient wants to explore, depending on their level of
Yeah.
trust of you and the medicine behind it.
It's an investment. It's an investment on the front end of the relationship. And then you have articulated several tools and skills throughout this conversation that demonstrate that even when you're in that investment phase, kind of early on, or building a relationship or trying to help understand a patient, that there are ways to do that with some efficiency and effectiveness, and kind of ways to focus and hone that aren't so even when you're really investing in a new patient or new relationship, there's still ways to do that without it being this overwhelming burden on your time and your energy, which I think a lot of physicians feel like patient-centered communication just means them sitting and like getting this dump. And it's not, for the reasons that we talked about today. But then also, like you said, it builds more effective and focused and helpful communication down the line, because then you've got that trust. And like you said, your recommendation goes far. And also, you've demonstrated that you're available and reliable to answer questions thoughtfully as they come up. And as the patient identifies what's important to them, they feel like you have a rapport where they can bring that forward proactively. So it's a win-win, really, as you build a practice around it, around that type of communication style.
Yeah, and I think that there's a lot of flexibility. I don't think I've mentioned the Calgary Cambridge model. I think I alluded to it earlier and how physicians are navigating both building a relationship and doing their medical decision making. And in a traditional appointment, that has certain phases, including the physical exam and
Hmm.
the assessment and plan and recommendations piece of things. I think it's also really scalable so that you can be thinking about landing with a patient where you have 10 minutes
Hmm.
and thinking about like what could I do to help this person in 10 minutes? What could I do to help this person in 25 minutes? What can I do to help this person in 45 minutes? And really, if you're explicit about time use and you're aware that you're building a relationship and collecting that data all the time
Hmm.
about medicine, you can really think about being interrupted at any point and saying, "Oh, well, based on what we know now, here's what I think. What do you think about that? Let's get that done." And I get a sense that like for our street medicine colleagues that are
Hmm.
out
Hmm.
in all of these
Yeah.
different settings, that they're doing a lot of that scalable stuff just all the
Yes.
time.
Yeah. And again, it's so translatable. Like it's exactly right. And that's, I think, too, my example of that parallel in the substance use realm, and lots of crossover with our unhoused folks, of just learning some of those skills. Scalability is a great word, because I think we sometimes, as clinicians, physicians, need permission to like do less, say less. And it's not that we're not being effective. It's, again, just feels like less because we're not eh, tackling this huge scope every time. We're being thoughtful about what we are doing. And to me, some of this appeals to the desire or instinct in me to go, whatever I'm doing for my patients or in my work, I want to be doing well. And in the early days, or when I had less skills or less tools in my toolbox, that to me meant doing an encounter well or taking care of a patient well meant like doing the most. and regardless of time frame, regardless of complexity, and really I wasn't being effective, right? I wasn't doing it well because you're just in this, you're mired in a bunch of really competing priorities in a really discrete time frame, and really learning to go, doing something well often means scaling down and honing in, and the patient leaves with their cup just as full or more full than if you send them out with 6 problems and a bunch of like follow up that you didn't really have time to go into, and a bunch of generic recommendations and a sense of being rushed and flustered. So you're absolutely right that when we're working with under-resourced colleagues or under-resourced patients, or patients who are dealing with life or death issues, it forces us to hone in and prioritize and focus and scale in a way that we definitely could apply more to more day-to-day encounters, and I think find, a really refreshing and helpful change. And our patients, I think, would find that too.
One of the things that I hope for is that as our residents grow in their skills, that they'll get to a point where within the first 3 to 5 minutes of an interaction with somebody, that they'll know what it's going to be about.
Yeah. You
And
talk
that
about that with them a lot, and I think that's really good.
what's this about?
Yeah.
And I connect that sort of up with um, what has seemed like my own personal work throughout my career to say less.
Yeah.
Um, because the more I'm saying sometimes, the less
Yes.
effective I think I'm being, and the less
Yes.
for sure listening that I'm doing.
Yeah.
So if I can know what an interaction is going to be about, and I can really hone in on the high priorities and the pertinent data, then that's going to make it feel much more effective for everybody because we're all
Yep.
focused.
Yep. I it's just very true. I have a similar goal. That's really, as I've progressed in my career as a clinician and as an educator, saying less has been a big part of that, for the reasons exactly as you described. That usually it means the more I'm saying, the less I'm listening, the less I'm thoughtfully listening. And also just decompressing, and that need to be the most and offer the most. And I definitely, you and I are chatty folks. We're a family physician and a clinical psychologist. And the impulse is overwhelming to me to share my knowledge with learners or with patients. And it feels so good, and it's so well intended. And for all the reasons we talked about today, it's a more skillful and helpful effort or practice to hone that. It's really just kind of a, being being more thoughtful and precise. It's, whatever the metaphor is of where we're using a really fine tool as opposed to like this buckshot of bleh, my knowledge and my education. And so it's evolving. And I think we want any clinicians or physicians, providers listening to also just feel permission to be imperfect themselves, and to move through this type of practice of patient-centered communication imperfectly, and to find ways that, you've offered lots of helpful scripting today, which I love, and trying some of that on and figuring out what is your, as a provider, what's your authentic version of that script or of that strategy, because it's got to fit your rhythm. And so I encourage our learners, I encourage anyone listening to practice, to find some of these strategies and scripting to practice in a way that feels really organic to them.
Organic, maybe evidence-based.
Yeah, also
As
that.
as we're wrapping up, it occurs to me that say less patient-centered communication would be a lovely title for a podcast episode.
Yeah.
I don't know that there's a title for this podcast at this point, for our avid listeners to really be
Yeah.
able to tune in
Yeah.
on a regular basis.
I love it.
But it's something that people who listen to this particular episode could
Mm-hmm.
reach out with what their
Yeah.
suggestions are about titles.
Yep.
For sure, their main takeaways.
Yes.
I yeah, I assume that there are going to be social media ways to respond to this, but I have no idea.
And hopefully in whatever format this is put out, maybe an episode description, because then it would be nice on there to have some bullet points that you made and really concisely signposted throughout, where we have some of those key
Wouldn't that
elements
be
that we
great?
talked about. Yeah, so we'll hopefully have that. I love the idea of a podcast being called Say Less, even though it is us really talking unopposed for almost an hour. I think that kind of delights me. We're talking about how we should be talking less.
Yeah.
And
Well,
I
we're
think
getting it out of our
that's great.
system,
Yeah,
and there's a certain
exactly.
sort of irony
Right,
in that because
right.
we are filling this space with a wall of words for everyone to sort of decode. But in
That's the
fairness,
point of a podcast,
it's the
also.
point of a
Yeah,
podcast, and we don't have
it's
somebody
serving the
other than
people.
ourselves to listen to. So
We're saying more now so that our colleagues will be empowered to say less later. And that's really the service that we're providing.
exactly.
We're willing to
Well,
fall on that sword of saying more now.
that's right. That's right. And maybe looking like hopeless idiots. Who knows? I know for my part, it has been a delight. I always learn so much from our
Oh,
conversations, Kari Beth. I appreciate you.
yeah, likewise. And I appreciate you soliciting my thoughts and then really beautifully packaging them into actionable things. I kind of like being the person that just gets to ramble about my big ideas, and then you pluck from them these great pearls. So I appreciate that.
Well, you are always welcome back on the podcast.
Say less, colon,
Say less.
patient-centered communication.
So good. All right.
Thanks, Chris.
Take care of yourself, Kari Beth.
Bye.